It's a pleasure to be here and to go through some of the work we did with the HIT guideline. I'm sorry about the title, I couldn't come up with anything more jaunty than that. It's just the what, when, how, why, where and now what of HIT testing. No disclosures. Obviously, because I don't get out much the chance to bang on about what's happened in Oxford in the past and what its contribution to coagulation, I can't miss an opportunity like this. This is our state-of-the-art facility up there in the top left-hand corner in 1964, where Robert McFarland postulated the enzyme cascade, which he produced in exactly the same year as the waterfall sequence came out from Davy and Ratnoff in the States, and he pipped them to the post by just a month or so between Science and Nature, and we now talk about the enzyme cascade, we don't talk about the waterfall sequence, so I think we won that one. That's him in the bottom left-hand corner with these two scientists, Rosemary Biggs and Ethel Bidwell. And I think probably you can see they're discussing the finer points of ISO 15189, 1964. Rosemary Biggs actually went on to generate the thromboplastin generation test, and she actually used that to identify factor IX deficiency. So it was very good scientists for their time. This is where we are now, so we've moved quite recently to our new centre. So what sorts of things are we doing there now at the Haemophilia Centre? Well, obviously for the chili aficionados, that's a Hungarian wax, which we've had a good season this year. Some bird's eye chilies, which are just colouring nicely. And our pièce de résistance, we had the Dorset Nagers, so they're very good, and they're going to make some good vodka, I hope, this year, but dangerously. No coag involved? Well, not to be so sure. Capsaicin, it actually has an effect on coagulation, so maybe we can do something with some platelet aggregation. But it has had some impact. So yeah, maybe it had more to coagulation than you think. But anyway, I'm here to talk about British Society of Haematology and the Task Force Committee. This was something I was involved in. I've just finished my stint on it. And it's a very good group of consultants and scientists who produce some very good up-to-date guidelines, taking the things that have been published. There's currently 4 of them in place, and obviously we're interested in the hemostasis and thrombosis group. There's about 13 members who meet about 4 times a year, and I would strongly recommend, if you get the opportunity as a scientist to participate, it's been very rewarding. So this is the website. I'm sure you've all been to the BSH website and looked at the guidelines, and yeah, it's a very good resource available to all. So particularly I want to talk today about the heparin-induced thrombocytopenia guideline, that came out last year, and Deepa, who was first author, I think we'll be hearing from later. So, HIT testing. What are we testing? When, how, why, and now what? So, back to basics a bit. What's heparin? Well, I think hopefully we're okay with heparin. What's heparin? Well, it came from an extract in 1916, a fat-soluble extract from liver, which was then made water-soluble and given the Greek name for hepa, for liver, was given the name heparin. So a long-chain mucopolysaccharide, so a long sugar chain molecule. But the important bit is the degree of sulfonation along here. So the sulfate molecules that run the top are highly negatively charged. So you end up with a long string molecule, highly negatively charged, and that's the important component. And with this highly negatively charged, therapeutically, unfractionated heparin binds to antithrombin, upregulates it several thousand-fold, provides the neutralization, the therapeutic neutralization of factor 2A and 10A. So it's a very good molecule that's been used therapeutically. So heparin platelet factor 4 complexes are associated with heparin-induced thrombocytopenia. So what's platelet factor 4? So platelet factor 4 is a chemokine that's produced and stored in the platelet alpha granules. Usually it's a 70 kilodalton molecule forming either in single components, dimers, trimers, but the one that we particularly hear about is the tetramer, the PF4 tetramer. And it's a chemokine, so it's a basic housekeeping function. So it's associated with the body's immune response. And this is its day-to-day job as it's released from the platelet, and it binds, it's highly positively charged. So it goes out looking for negatively charged bacterial coats and bacterial surfaces to bind to. And so the combination of the positively charged platelet factor 4 and the negatively charged bacteria produces a combination for an antibody production, and this is completely normal. Bacteria removal with a negatively charged binding from platelet factor 4. Once it's bound and you've got an antibody produced by the natural immune response, it binds to the Fc gamma receptor on platelets, causing their activation and the removal of the bacteria. And as I say, this is a completely natural process. Where heparin gets involved on this sliding scale here is if you have therapeutic unfractionated heparin. In the bottom left-hand corner here, we have high concentration heparin coming into contact with platelet factor 4. And in that concentration, it doesn't interact particularly well. If you look at the top right-hand corner, if you have low concentrations as well, then low concentration heparin also doesn't interact. So there's a sort of Goldilocks and the three bears. Somewhere in the middle here, if you get your platelet factor 4 and heparin just right, then you get platelet activation. And this is the center of heparin-induced thrombocytopenia. So what are we testing? So we see, or we're told about in the lab, the production of thrombocytopenia plus or minus thrombosis in the presence of heparin. Type 1 is more frequent, so a lot of patients, up to a third of patients who have unfractionated heparin, will have a direct response to heparin. Within the first 3 days, you'll get a transient drop in platelet count, but it will return to normal. It's not associated with thrombosis. So clinically, we're not interested in those. It's the type 2, less than 5%, with a complete autoimmune response. So possibly within the first 2 weeks afterwards, we have an IgG response, and up to half of those can have a thrombosis through platelet activation, monocyte tissue factor activation. Mostly IgG, although some of the kits will pick up IgA and IgM responses, and the likelihood of producing a response depends on the chain length. If you have full unfractionated heparin, you're likely to have more chance of a response than low molecular weight heparin, and then down to the smaller molecules like fondaparinux. So clinically, when are we going to test for them? We know that we've got plenty of patients on heparin, so we don't want to be screening them all. So classically, the clinicians are introduced to the 4T score. So some sort of assessment of what sort of platelet presentation they've got, what size the drop is in platelet count, scoring more points. When does it happen? Does it happen like an immune response after 10 days, weeks, 10 days? What sort of thrombosis occurs? Do we have a new thrombosis? And is there any other explanation? So if we score all of those, the most direct, highest points will give us a 4T score of either low, intermediate, or high risk. And we often see that in patients, as I say, who are on unfractionated heparin over low molecular weight heparin, surgical patients rather than medical, so patients who are more likely to be activated, those on treatment doses, and those with major trauma. So these are all activated platelets expressing more Fc receptor, and the more the likelihood of causing aggregation. So what can we do in the lab? How can we test? So first line of audience participation this morning. Who gets to see a 4T score? Who tests for HIT testing? Hands up for HIT testing. Hands up who see a 4T score beforehand. Well done, that's good to see. So not everybody gets to see a 4T score before it presents. So at about the same time, we have the lab assessment. We've got two options. We can look for the antibodies, the anti-platelet heparin platelet factor 4 complex in immunoassays, or in the blue boxes, we can look for functional assays. So can we demonstrate that the platelets actually are being activated? So on the far left-hand side, semi-quantitative assays, these are the yes-no. Can we find antibodies? We don't know what they're doing. And as I say, this may be in up to a third of patients who have a response producing antibodies, but it doesn't mean that you actually go on to have full-blown HIT. Quantitative automated assays, and I guess that's probably where we are for most places at the moment, being able to put a number to it, and the quantitation is important, and I'll come back to that later. Originally coming from ELISAs, so quantitative ELISAs, still quite useful. I'll explain a bit more about those. Moving on to the straight aggregation. Can we demonstrate that if we put platelets in the presence of heparin, we get aggregation? So the original HIPAA. But moved on now to flow cytometry. Can we demonstrate activation? If we can't demonstrate aggregation, can we demonstrate activation with flow cytometry instead? And the words which I think Steve doesn't use, gold standard. The gold standard test is serotonin release. We'll have a look at that. So I drew them in that order, particularly one case, just so we could get the yellow boxes on the end. The more you come down the page, the longer they take. The more you come to the right, the more complex they are. So we're going to have to picture a plan here of which of these assays best works for the environment that you're in, and which of this selection. So the first ones here, the semi-quantitative immunoassays. We've got the COVID-like cards here. I think you'd recognise of Stago's IgG card that produces a line on the card, a lateral flow assay. I've also put down here the column spin technology that was here from Biorad, which the transfusionists might know. It's something which was available but has subsequently been reduced from the market, so it's not easy to get access to it anymore. But these are semi-quantitative. They'll give you a line on a card and a yes, no, but no more than that. And they're very good for rapid testing. You don't need much technology. You can do these bedside. And there may be some sort of trade-off in terms of the quality of the sample you need for fresh samples, and for rapid response they are useful, but they do come with the limitations. This is the automation one. Sorry that the slide's a bit busy. So latex beads, putting platelet factor 4 complexes, and then putting antibodies on latex beads and making a competitive assay. So patients with antibodies, it's actually inversely proportional. The more aggregation, then the less antibody is present. All you need to see basically is when you quantitate them and subdivide them. Those on the right, on the top here, was a prospective cohort of 400 using this assay, and the positivity lies to the right when they segregate them by an arbitrary scale of 1 to 16. And on the bottom here, this was a load of 125 positives that they already knew about, and they also came up to the right. So it does seem to pick them all up. Just of note, there's a couple on the left-hand side there, and both of them small dots of red over in the negative side. So there are some here which are negative against the gold standard of serotonin release. And with a chemiluminescent platform, so this gives some better sensitivity here. And so this graduations of putting a cutoff, a chemiluminescent cutoff in the middle of an arbitrary scale of 1. The more you come to the right, you've got some very good positives. And there's no surprise if you've got a stonking antibody, the likelihood of full-blown hit is that much more likely. ELISAs, now ELISAs usually is the start of the development of an assay. We still have access to ELISAs for IgG, A and M hit testing. So why do we keep them? So I mentioned before that if you get the concentration just right of platelet factor 4 and heparin complexes, then you get the antibody production. But if you have too much or too little heparin, then the combination doesn't appear. And this can be used in the ELISA techniques here, that the green dot in the middle is a positivity associated with a low dose heparin in ELISA. But if you increase the dose of heparin, then the positivity goes away, and with no heparin as well. So you get a screening technique where you can add more or less heparin and show that low dose heparin is associated with heparin dependency. And that also can be graduated, so the higher the optical density here, then the more likelihood, the positivity in the release assays. Functional. So for a long time, people have had access or tried to do heparin-induced platelet aggregation, and it seems to be quite straightforward. We use low doses of heparin. So in these plots here at the top, heparin 0.1 or 0.5, low dose, ideal combination. Then you get the aggregation and the activation of your platelets. If you increase the heparin to a high concentration, then you don't see the same thing again. And you can reproduce that again on the electromechanical techniques as well. So you can show impedance, and that's the same here. Low dose, and this one is 1 unit, 200 unit. High dose, you get negativity. So you can demonstrate that. Serotonin release, let's get serotonin release out of the way. So serotonin release seems straightforward. You just take your platelets and you load them up with your radio-labeled carbon 12 or 14, and you incubate them, you wash them, you make a pellet, incubate them with low-dose heparin, out comes the radio-labeled serotonin, and you pick up the release, you pick up the activation. It's great. Obviously, access to radio-labeled techniques, not so good these days. So very sensitive. It still takes allegedly 4 hours to do, and you have access to isotopes. So this is where I think we probably are moving to. This is flow cytometry as an endpoint for platelet activation. And we can see here, going from top left, the box is just standard gated platelets on flow cytometry by density and a platelet marker. And then second one along B is unstimulated cells. There's nothing in the top right-hand box. And if you stimulate in C with a calcium, a standard platelet activator, then you get full movement and full activation of the sample, which you can pick up. If you compare that to the bottom three, left-hand side, you've got a negative, no heparin trace. One in the middle, you can see that the plot has moved to the right with the incubation of low-dose heparin. But if you increase the high-dose heparin on the right here, then the positivity has disappeared. So you can demonstrate reaction to low-dose heparin in a flow cytometer. All we need is a flow cytometer, and 2 to 3 hours. But this is becoming more online and I think is going to replace the serotonin release. So this one's been floating around for some time. You'll find this in all the textbooks. This is the iceberg model of everything. So this is HIT testing. Historically, we had the ELISAs, IgG, mRNA. You can pick those up in a lot of patients, but it's nothing to do with HIT testing or nothing to do with HIT antibody and thrombosis. More importantly is the IgG ELISAs, the serotonin release. But now we have overlaid on that, I think, a whole plethora of tests that we can use. We've got lateral flow, latex immunoassay, chemiluminosity, and both on automated platforms, flow cytometry, but we still can't differentiate between those which are going to go for full-blown thrombosis. So now what? So it's easy, we just stop the heparin. And we do have some alternatives, and we need some alternatives because it is a highly thrombotic presentation, so we need 4 weeks with no thrombotic complications. We're going to need 4 weeks of anticoagulation, 3 months if you have a thrombotic complication. So we're going to need to do something. We're going to also have to learn, probably from our transfusion colleagues, is to issue out alert cards. We're going to have to get our patients to carry them. This is a long-term immune response that they may well present. And funnily enough, don't give them heparin again because it will come back. We do at least have a variety of alternatives. So we have an access now to a number of other anticoagulants, which of course we'll be told we have to measure. Probably first and foremost argatroban, as long as your liver function's fine, and we just use the APTT to measure it, don't we? We'll come back to that one. Bivalirudin, as long as your renal function's okay, we just use the ACT. Danapoid fondaparinux as well we can use with an anti-10A assay. So we do have some choice. And it goes on. If we want to switch, if it's more severe, we can actually switch to a vitamin K antagonist, and we can even move on to a DOAC. And if all else fails, we've got IVIG to try and block the FC receptor antibody response or full-blown plasma exchange to remove the heparin platelet factor 4 complexes. So a quick mention of argatroban over here on the right-hand side, just on our thrombin, ways of neutralizing thrombin. On the left-hand side, we have unfractionated heparin with its highly negatively charged binding to the exocytes on thrombin, and by the action of antithrombin neutralizing it. The benefits of argatroban as a single direct molecule is it doesn't require the function of anything else and it can bind directly to thrombin. Looks good when we come to measure the APTT. If we look along the bottom here, APTT ratios for argatroban, that's great. If you use a nice synthetic model like this, in vitro, doesn't matter what reagents you use, you've got a nice dose response, so there's no problem using APTT, is there? You try it in patients, and that happens. So it's just synthesillin actin, and this was a few years back, so much the same as unfractionated heparin and APTTs. It's not quite as clear-cut as it may lead you to believe. But at least we have some alternatives. There's a lot of thrombin, direct thrombin inhibitors, ECRIN, chromogenic assays as well. So there is a wide range and we can quantitate now. So I think we need to think about quantitating our anticoagulants rather than just talking in APTT relative units. So here's the list then that we've just been through from semi-quantitative, and you can see it's, well, this is straight from the guideline. You sort of pick what you want in terms of what access you've got to automated platforms, the sort of time and the sensitivity you want. And we know the functional assays have issues with platelets provision. So what next then? So anybody remember this guy? He popped up a few years ago. So we got some vaccination. A number of us had adenovector vaccines passed out, and after a time we started to spot thrombosis. The patients presented with symptoms 5 to 30 days post-COVID, and they had thrombocytopenia and raised D dimers, and they had positive anti-PF4 ELISAs. So this is HIT, but how come these patients have been nowhere near HIT? So remember what I said before, this is the adenovirus vector on the left-hand side, highly negatively charged surface. What's PF4's job? Bind to highly negatively charged surfaces. So we're seeing vaccine-induced thrombosis, and so without the presence of heparin, we're still seeing patients presenting with it. So NECWAS participated in the vaccine-induced thrombosis samples and sent out 6 samples, of which the first 5 were VIT positive and a negative. Just some of the responses we'll whiz through quickly. So the Stago stick, so these were positive samples, 1 to 6 along the top. most of them were negative. So of all the participants, most of them didn't pick it up with a stick, a few did. With the Diomed card, sort of an equal split of people picked it up and didn't. The ELISAs, they all picked it up. So the ELISAs picked up the VIC positive samples. The AccuStar, none of them picked it, or most of them didn't pick it up. So negative in the AccuStar automated assays. In the latex assays, mostly negative as well. Flow cytometry, an equal split. Platelet aggregation tests, an equal split of positive and negative. Serotonin release of those who did it, a couple of them missed it as well. So a real mixture of abilities to pick this up. And so I think this is a great overview of it. And obviously, Walkenton and Greinacher are the people who know about this. And so they produce something like this, which I think works very well with the classic hit in the Venn diagram, covering what we're used to seeing with classic unfractionated heparin incubation. A smaller population of acquired HIP who may have had some sort of presentation, but that may be hep flushers and low-dose heparins, fondaparinux, and so that's the smaller subgroup. And then just outside the box on the right-hand side here, a small group who have been nowhere near heparin but show all the same sorts of symptoms. And a lot of these are associated with vaccine-induced or post-op infection, where there's a high infection rate, and the PF4 complex is doing its job. And there's a very good review here, which I would point you to, suggesting that they can go further and show all those on the left-hand side using the classic hit that we expect, and those on the right-hand side not requiring heparin, and identifying on the platelet factor 4 molecule where the binding is. So it can go into quite detailed now about exactly what the reaction is and where you're likely to pick it up. So in summary then, we have a variety of tests, semi-quantitative one end, all the way through our automation with various sensitivity on various platforms readily available to us now. We have access to functional assays. We don't need serotonin release. And we can probably, if we can find a good source of platelet donors, then maybe flow cytometry is a better solution. We have VIT testing has just put the spanner in the works. And we will find some patients who are coming up on their ELISA, maybe a few on our automated platforms, but it won't be very standardized. And basically we have a choice. So maybe a bit like the chilies again, we do have a choice here, something for everybody on the scale, depending on your tendencies. Thank you very much.